Thank
Okay.
you.
Thank you.
All right, I started the recording. You guys should be good to go.
Thank you. Okay, so it looks like people are still joining. It's only 12:02. But for those of you who are here, let me just make some announcements. I'm Dr. Tanno. I'm moderating these webinars and planning them. So if you have any comments, there is a email address that you can email on our website. If you just click on the webinar link, you can see upcoming webinars, past webinars, and then the email address for any kind of feedback, ideas, anything like that. It's appreciated to just hear comments and see if there's anything we can improve. And then no webinar on Friday. So for those of you guys who tune in regularly, I'm sorry, only 2 this week. And then next week, Monday the 8th, we have another COVID update. So Dr. Tannenholz and nurse practitioner Christina Schrack, who have been our, the face of our practice during this COVID epidemic. They are going to be doing an update to update you on what the practice is doing and what our current protocols are. And we have had a lot of questions about the antibody testing, so I've asked them to specifically address that kind of a concern. And then that's Monday. And then we haven't quite nailed down whether it's going to be Wednesday or Friday, but there's going to be a talk with myself and Dr. Christina Council about some disparities in health among different races. We thought that would be a timely discussion to have about sort of the differences in care that people get around this country. So both of those talks should be pretty good. I think next week will just be the 2 talks as well. And then we'll go from there. So today we have our 2 gastro doctors, which is remarkable for them to be together in the same room at the same time, even though it's virtual. Dr. Tesfaye and Dr. Wu. And they are going to talk about irritable bowel syndrome. Both of them are here. They are doing virtual visits with their patients, and then they can speak to the current state of screening colonoscopies and any other kinds of gastro procedures that they would otherwise normally be doing. I think that they're doing some, but I'll let them fill you guys in on what the status is. And then just as a reminder, all of the doctors and all of the nurse practitioners are seeing patients as virtual visits. So if you have any concerns, if you're behind on your routine care, if you wake up with anxiety about something and you have a question about COVID or anything, we're all happy to accommodate you. We have a lot of openings right now. So feel free to schedule with your doctors. We're not busy. We're mostly at home, so don't feel like you're bothering us in any way. We're happy to be here. All right, well then I will let Dr. Tesfaye take over, and then I think Dr. Wu is here for some questions and moral support.
Okay, good afternoon, everybody. My name is Dr. Tesfaye. I'm one of the GI doctors at Rockland Internal Medicine. Thank you for being here virtually. We'll talk about irritable bowel syndrome today, and I'll dive in. Okay, let's see. Next slide. Okay, for some reason I can't move the slide.
Is Travis doing your slides? And is Travis?
I was able to move the slides with Travis' help, but it's not, for some reason right now it's not. Okay, all right.
Oh, there you go.
So the outline of my presentation, I'm going to talk a little bit about the history, the epidemiology, the disease burden, the pathophysiology, signs and symptoms, types and diagnosis and management of irritable bowel syndrome. I'm going to briefly talk about these with the time that we have today. So the earliest description of symptoms defining IBS was described back in 1849 by Cumming. He described it saying the bowels are at one time constipated, at another lax in the same person. How the disease has two such different symptoms, he said, I do not profess to explain. But the actual term of irritable bowel syndrome was described in 1966 by C.J. Delore, but in between, there were different terms used to describe irritable bowel syndrome, such as nervous colon, irritable colon, unstable colon, colonic spasm, and the like. When we come to the US, the prevalence, IBS affects about 10 to 12% of adults in the US. It's more predominant in females. Usually people are diagnosed before they reach 50. And these are some of the well-known people that are described that they've been affected by IBS, including John F. Kennedy and Tyra Banks. So although it affects 10 to 12% of adult population in the US, only 25% of them seek help from their primary care provider or from their specialist. The remaining 75%, maybe they have learned to live with their symptoms or they have not discussed their care with their physicians or providers. So irritable bowel syndrome, it's the most common GI diagnosis among gastroenterology practices in the US. It's one of the top 10 reasons for primary care physician visits. It affects predominantly females, as I stated earlier, and it's estimated about 70% of the sufferers are females, but any gender, any age and race can be affected by IBS or irritable bowel syndrome. The burden of the disease is that IBS symptoms can reduce someone's well-being, your well-being. The fact that you're having abdominal pain, cramping, and bloating, change in bowel habit, including constipation, diarrhea, or urgency throughout your day, reduce your sense of well-being. By so doing, it also decreases your productivity. So back in the 1993, Grossman showed that people with IBS are absent from work or school 3 times more than their non-IBS sufferers. So come to this one a little later. There's also post-infectious irritable bowel syndrome, which is after someone has infection from either bacterial, viral, or food poisoning. About 60% of those people remain having symptoms even after the infection is resolved for about 6 months upon follow-up. And usually these people have diarrhea predominant IBS. So when you compare pain threshold in IBS patient, why do they have more symptoms? There was a study done by putting balloon in the rectum of people, normal people and people with IBS. And as you can see, people with IBS reported pain at a very much lower threshold. The threshold for pain was found to be much lower than the normal individuals. So currently the criteria that we use to diagnose IBS is called the Rome-4 criteria. If someone has recurrent abdominal pain on average of at least 1 day per week for the past 3 months, associated with at least having 2 or more of the following supporting symptoms, such as altered stool frequency, stool form, altered stool passage, such as straining or urgency, or if they have mucus in stool, abdominal bloating, or subjective distension, they can fit the diagnosis of IBS. But the most important thing is before we diagnose someone with IBS, we have to rule out other causes of the disease. So any of the symptoms that I described earlier should not be explained by identifiable structural or biochemical abnormalities. So these are functional symptoms without any lab or imaging or endoscopic abnormalities. So when someone presents with any of these, irritable bowel syndrome, we can't diagnose irritable bowel syndrome if someone presents with anemia, fever, rectal bleeding, weight loss, or the initial onset is after the age of 50. If any patient described any of these, then this is less likely to be IBS, and we have to look for other causes of the symptoms. So there are, based on the American College of Gastroenterology 2018 monograph, they have classified IBS into 4 groups. IBS that is, IBS with the predominant symptoms diarrhea, that's diarrhea predominant IBS, constipation predominant IBS. There's a mixed of time where someone has both symptoms on and off at different times. And there is IBS with, which they call it unclassified. They cannot put them in any of these 3 groups. So when we order any test, when someone presents to us with symptomatology of IBS, there are a few things to consider before ordering the test. That one is the pretest probability of the disorder based on the prevalence of disease in patients with specific symptom complex. The second is how accurate is the test, how sensitive is the test that we're ordering, and how specific it is. For instance, as you can see here, celiac disease tends to be more common in IBS patients or people with IBS compared to the general population versus colitis, colon cancer, infection, thyroid issues, and other things are almost similar between IBS patients and the general population. So some of the tests that we do when we see someone who comes with IBS, usually a basic blood work, it can be done by the primary care provider, a stool test to make sure this is not infection, just like giardia. We check for the presence of blood in the stool, if there's any inflammation, if there's any suspicion for ulcerative colitis or Crohn's disease. As I mentioned before, it's very important to do celiac test to make sure there's no gluten intolerance. Lactose intolerance, we do perform the test in our office, but at the same time, we can do elimination diet for 3 to 4 weeks to see if someone gets better after eliminating lactose from their diet. The other test that we perform is a small intestinal bacterial overgrowth test, or SIBO test, which we do breath test in the office. Most recently, there are more studies coming out saying maybe the presence of abnormal bacteria in our small intestines might predispose us to develop symptoms of IBS. The other one is if someone has upper GI symptoms, more they're having bloating or discomfort, gas, bulging, it's well worthy to do H. pylori breath test or stool test to make sure we rule out infection in the stomach. And based on individuals and their symptoms, we sometimes you do endoscopy and colonoscopy as well as imaging such as ultrasound and CAT scan to make sure they're not carrying other diagnoses other than IBS. And I want to say each and every one of the tests that I described are individualized. We decide based on the symptoms, the age, and the duration of symptoms. So some of the differential diagnoses for IBS include malabsorption, dietary factors such as gluten intolerance, infection, inflammatory bowel disease, and gynecological disorders such as endometriosis. People with these problems oftentimes present with very similar symptoms as irritable bowel syndrome. So it's noteworthy to make sure they don't have any of the symptoms. So what is the current management component of IBS? Of course, education. We have to educate our patients about the symptoms of IBS and how to treat it. Reassurance, since this is not organic or structural disease, a lot of times patients come with fear of having malignancy or other serious illnesses. So it's always good to reassure them. Dietary modification is important. Having a dietitian involved in the care of the patient helps in having making their diet decisions, even when they're doing elimination diet. to make sure they have the appropriate nutrients when they eliminate certain foods. And we do symptomatic treatment. There is also psychological and behavioral treatment, and also important to set realistic goals, what to expect at the during and at the end of treatment. So for someone whose main complaint is abdominal pain, we use medication, smooth muscle relaxants, medication like hyoscyamin and dicyclomine to combat the cramping and the abdominal pain that they're having. In severe cases, or if they don't respond to hyoscyamin or dicyclomine, we can sometimes use small doses of tricyclic antidepressants, such as amitriptyline, to help with the symptoms. If someone is presenting with diarrhea, predominant IBS, the goal of the treatment is going to be to increase the stool firmness, decrease stool frequency, and we use diet and certain drugs to help manage the diarrhea symptoms. If the predominant symptom is constipation, usually we encourage our patient to make certain lifestyle changes, including increasing fiber in their diet, increasing fluid intake, that means water, not caffeine. And if they don't respond to the lifestyle change, we go to the next step, which is giving them laxative or medication. This can be either over the counter or prescription. So recently, in the past few years, treating irritable bowel syndrome, especially irritable bowel syndrome with diarrhea with antibiotic, has come into have been studied quite a bit. And the antibiotic of choice, or the most studied antibiotic, is rifaximin, which is an absorbable antibiotic that we usually give for 2 weeks, 3 times a day. And this has shown benefit in our patients with irritable bowel syndrome with predominant diarrhea symptoms. Also, relaxation is a good one form of treatment, as some of the etiologies of IBS have been attributed to stress. So relaxation, things like yoga might help with IBS if stress is a main factor in causing IBS. Probiotics and IBS, there are several studies being undertaken. The current evidence is weak. So at this point, there is no strong recommendation to use probiotics in the treatment of IBS. Cognitive behavioral therapy, this is done by psychiatrists and psychologists, and I hope our psychologists would be talking about this in future in one of our webinars. There are several clinical trials done, randomized clinical trials done to evaluate cognitive behavioral therapy in the treatment of IBS. And I would say most of the data shows this is promising. Then coming to the non-traditional remedies, peppermint oil has an effect of relaxing the GI smooth muscles, so might be helpful for a patient whose predominant symptom is cramping or abdominal pain. The only caveat with using peppermint oil is, since it does relax the smooth muscles in the GI tract, sometimes it might make patients prone to reflux symptoms. So be careful in using if you do have acid reflux symptoms. Also, acupuncture has positive results in studies in treatment of irritable bowel syndrome. There's also studies done for gut-directed hypnotherapy, but I would say at this point, the evidence is insufficient for gut-directed hypnotherapy. Coming to surgical treatment for irritable bowel syndrome, occasionally IBS symptoms may be attributed to a non-functioning gallbladder disease or chronic appendicitis, fibroids, or a tortuous colon. The problem is, even after taking the gallbladder or the appendix, IBS symptoms rarely improve after surgery. And currently, unfortunately, IBS patients are are 2 to 3 times more likely to undergo unnecessary surgery because of the above. Sorry for the slides, but this is to say that sometimes it would be necessary to use multiple medication needed to treat symptoms because patients can present with 2 or more symptoms, like they might have lower abdominal pain, but at the same time bloating, or they may have urgency or altered stool form or stool passage. So it may be necessary to use laxative, but at the same time, things that help with their pain or bloating or discomfort symptoms. So in summary, irritable bowel syndrome is a chronic medical condition characterized by abdominal pain, diarrhea or constipation, bloating, passage of mucus, and feeling of incomplete evacuation. The precise etiology of IBS or the reason for IBS is not completely known even in 2020. The current treatment is more focused on relieving symptoms rather than curing the disease. And although many IBS patients complain of symptoms associated with food, only 1/4 of patients do have true food allergies. So at this point, we don't usually recommend doing food allergy testing, be it skin prick test or allergy testing for everybody. So specific treatment strategies are determined by individual patients and their symptoms. And lifestyle modification and possible alternative therapies may relieve symptoms, like I discussed, like peppermint oil. And surgery, unfortunately, has no role in treatment of IBS symptoms. So as a patient, when you come to your physician, and if you're having symptoms, and this would be for any symptom that you come to visit your physician, be clear on the reason for your visit. Before your appointment, you can write it down, or you can bring a family member to help you explain your symptoms. Review and characterize your main complaint. Let's see, if you're coming with abdominal pain, be clear in terms of specifying the location, the quality of the pain, what makes it better or worse, the time of onset, the duration. And if you had this for years, like this is chronic symptom, like chronic constipation or diarrhea or abdominal pain or bloating, be clear with your provider why you're seeking care now, or anything changed, if things are worsening or it's becoming more frequent. And share with your provider your worries and concerns. Are you worried about cancer, or are you worried about food allergy? And describe its impact. Let's say if you're having diarrhea or urgency, how is it affecting your daily life? And usually you probably would know, or you can describe what you think you have. Is it, you can describe what you suspect you have with your physician. So have goals and objectives for your visit. And have your healthcare provider as your partner and advisor in your care. I would say the best outcome is when you share in the clinical decision making. So I would say listen actively and ask questions if things are not clear. So this is, I know it's a very short presentation for IBS. Thank you for attending our webinar.
Yeah.
To Eleanor.
Let's see if we have some questions here. We do. Okay. So somebody asked about the low FODMAP diet. I have IBS and it helps a lot. Can you maybe explain what the low FODMAP is? I'm sure that most people on the call do.
Okay. So the low FODMAP diet is a diet that excludes foods that produce gas when we eat them. These are fermentable oligosaccharides and some things that contain fructose. So it's very helpful in terms of symptoms of IBS, especially bloating and diarrhea. we do have an outline of low FODMAP list in our office, which we share with our patient. But I would say some of my patients have found it a bit too restrictive. Usually the recommendation is to be on the low FODMAP diet for 5 to 6 weeks, if more difficult, up to at least for 3 weeks, and add back each food back to the diet to identify specific triggers. I usually would work with our dietitian to help our patients include the low FODMAP diet, but it's definitely, there are several studies that were done that have confirmed positive effect of the low FODMAP diet in IBS symptoms. But I think it's best to work with your dietitian in terms of how long you have to be on the low FODMAP diet to make sure you're not deficient, nutrient deficient, and how to add back things on the high FODMAP diet progressively to eliminate few things from your diet.
Okay. Yeah, and then you can also Google the low FODMAP diet. So sometimes I just print out a copy for patients. It's not something you need to come necessarily for us to give.
Yeah, I agree.
And then, okay, so let's see. So I've had IBS since 1979. Can the type of IBS change over the years from diarrhea to constipation?
Yeah, yes, that typically happens. Usually with age, motility slows down. So someone who starts as predominantly IBS diarrhea might have constipation later in life. And there are people with mixed IBS type where they have diarrhea, alternating diarrhea and constipation, and they don't have a normal bowel movement, and they just fluctuate between having extreme diarrhea or constipation. So yes, it can change.
Then, or I guess maybe on that vein, if you do have a change in bowel movements, what would be the reasons to seek to seek a visit with your doctor? Because I know that sometimes people have dramatic changes. We do have them go back and talk to you.
Yes, that's a very good point, Eleanor. So any change in bowel habit, and again, I say the treatment and diagnosis is very individualized, especially after the age of 40. Any change in bowel movement, I think I say speak with your provider or a GI doctor. So in that case, colonoscopy may be necessary, and this might be due to other structural disease like colon cancer. So I would say make sure you consult with your provider to make sure we rule out things like colon cancer.
And then there's a few questions here, but one is, can we see the second chart again, the percentage of people with other problems who also have IBS? So maybe just put that up while you're answering the next questions. Okay,
So the question is the slide for the percentage of people with other problems?
Yeah, the chart that has the percentage of people with other problems who also have IBS.
That's a good question. I don't think I have that slide. I'm not sure.
Okay, so maybe the person can, oh, I said she passed it, but hang on. All right, well, we'll come back to that. Maybe if there's something else you remember from the slide. Is that the one? Is this the slide to this viewer? Oops, the graph. No, okay. We'll post this, at the end of this, the presentation is posted so viewers can go back and look at it more closely if there are specific questions.
Okay, perfect. If there's any question, we can get back to them as well.
Yeah. And then, okay, so here, I get this question a lot. How does CBT help with IBS? So cognitive behavioral therapy, how does that help with IBS?
I guess one of the things which can lead to symptom of IBS has been found to be maybe stress, because there are the same serotonin receptors in the brain and in the gut. This would be more explained by our psychologists or psychiatrists, but my thinking is maybe helping them to cope with stress, helping a patient to cope with stress in terms of not internalizing it. Maybe I would say this would be more stress coping mechanism. But I would say I would leave this to our psychologists if they can explain this.
Okay. And then, does anyone know why post-infectious IBS lasts such a long time?
So some of the few studies that I have read, one of the studies found that they actually took biopsy from the rectum of patients, like after their infection has resolved. And in this study, they found more white blood cell count in those patients after they had infection, people who have with persistent symptoms. So I'm sure there's some physiological change once someone have infection. So there are studies, but that might be an explanation. There might be increased, and again, it's predominantly diarrhea. Might be a change in the gut microbiome. That is one explanation. The other one is there is more serotonin producing bacteria and in the gut. Maybe there's more serotonin production, which usually causes increased motility and causes diarrhea, but not completely known, I would say.
There's more chat on this slide. So let's see. So somebody said, is the chart with colon cancer and other issues, maybe 17 or so. So maybe, I don't know if you can look, I don't know. Otherwise we might just say. I don't think that's it. Anyway, okay. So let's see, other questions that are coming in. Oh, can you define mucus in the stools? Belen, can you define mucus in the stools?
So some amount of mucus is normal in the stool because our GI tract produces mucus normally. But if this is more than usual or excessive amount than your usual amount of mucus that you see in your stool, I would say that would be a reason to consult with your physician. But one of the diagnostics, one of the symptoms of IBS as described is increased mucorrhea or increased amount of mucus in the stool. But to a certain degree, there is some amount of mucus which is normal, but anything unusual, I say consult with your provider.
Okay, and then so we have a lot of questions. So hopefully we can get to most of them. What does the IB Guard pill help with?
So there is IB Guard and FD Guard. One of them has peppermint oil, and peppermint is a smooth muscle relaxant. So it helps with predominant pain or cramping symptoms.
And then the FD Guard, does that have a different
That's usually used for functional abdominal pain. I think the content is similar.
Okay. So maybe this is more of a discussion question than a specific question, but how are you seeing the pandemic affecting IBS symptoms?
I think I was discussing this with you, Eleanor, and Dr. That we've been seeing more either new IBS or exacerbation of IBS symptoms. I see that maybe due to change in diet, lack of exercise, due to homestay orders. But most of all, I think it's likely due to stress. There is definite etiology or physiology of IBS being due to brain-gut, the brain-gut axis. Anything that affects your brain affects your gut because there are more nerves and more serotonin-producing bacteria and receptors in the gut. So I'd assume that might be one reason. But if Grace is here or Dr. Wu is here, I think I would be.
I am sorry, I missed that question. Could you repeat that question again?
Oh, how, maybe why specifically do you think the pandemic is affecting increased levels of IBS symptoms?
Oh yeah, so we see IBS, just like Belen said, quite often, but lately I have to say the pandemic is bringing out the anxiety and the stress more. And as Belen mentioned before, there are a lot of serotonin receptors in the gut. And the way I describe to my patients is besides the brain, the GI tract has a lot of nerve endings there. And a lot of patients can present symptoms. They see their anxiety as GI symptoms, or they present with GI symptoms, abdominal pain, gas, bloating, constipation, etc. So definitely, I do agree that stress does bring on a lot of their IBS symptoms. And also because we're not exposed to other things, we're sort of limited in our house, we are probably much more sensitive to our symptoms too. I hope that answers that question.
Yeah, sometimes I have patients who I describe this as, before a big test or before you get on a flight or something that makes you anxious, you might notice some increase in your diarrhea. And so that's a normal sort of mind-body connection. And so it's probably a similar, it's different because it's IBS, but a similar idea of how stress can have these physical manifestations on your body. All right, so here's a question. It might be a little more specific, so this person might actually need to talk to their doctor, but can the symptoms also make the stomach hurt and nauseated? I have noticed that over the years, I have started to feel nausea together with diarrhea, cramping, and or constipation.
Grace, you want to answer this?
Yes, so we've actually had patients with IBS presenting with nausea symptoms too. So as Belen mentioned before, IBS can present with certainly the diagnosis of abdominal pain, changes in bowel habits, caliber of stool, frequency of stool, but we also have a different category, what we call non-ulcer dyspepsia or upper GI symptoms. So we have people who are very sensitive, presenting with lower GI symptoms, gas, bloating, constipation, diarrhea, etc. And we also have patients who present with upper GI symptoms, epigastric pain, nausea, vomiting, etc. So the type of medicines we use sometimes do overlap, but we've seen nausea as well. Of course, you also have to rule out other causes as well. Nausea is a very non-specific symptom. Medications can do it, even constipation can present with nausea. GI issues such as gastritis, ulcers, etc. can present with nausea. So we do go through the differential, but IBS patients can have nausea. The differential is very, very broad for nausea.
Yeah, and then somebody had asked for me to spell out the low FODMAP diet. I posted that into the chat, so it's I spelled it out there, but so you can see it, but it's MAP. So it's a little bit of an acronym. It's a big mouthful. What does the FOD stand for? I don't know actually. What is that? Do you guys know? It's a
Yeah, it stands for fermentable oligo monosaccharide and polyols. It's a mouthful. That's why we call it FODMAP, FODMAP. Exactly,
Yeah.
Belen mentioned, it helps with gas and bloating, and really the IBS patients seem to benefit from it. There are apps too, there are books about it, lots of information, but I do agree working with a nutritionist really helps.
Yeah, and sometimes when I talk about the low FODMAP diet with patients a little bit, it's basically it feels like a long list of random foods, so it's not totally intuitive. So I would really recommend if you Google FODMAP, you'll bring up a whole table of all kinds of foods to avoid, and then also work with a nutritionist or the gastro doctors could be a very helpful thing here, because it's not like other diets where we say, avoid sodium or we avoid fat. It's really it's a whole litany of different foods to avoid.
Yeah, and just to add on that, I agree with Grace. I think I stress upon the fact that it's better for them to work with their dietitian so they would not be nutrient deficient by following the FODMAP diet, and in guiding them to add the things that they have eliminated from the low FODMAP diet, as time goes on, so they won't be nutrient deficient.
Okay. So here's a question. What can cause dumping with a very low heart rate down into the 40s, 40 beats per minute? I think by dumping, they probably mean diarrhea, but maybe you guys are more familiar with that question.
So I would ask Grace to add upon this too. Usually dumping syndrome is in people who have some form of gastrectomy done. I usually see it in people who have part of their stomach or part of their duodenum removed. And this is, it has some neuronal and some anatomical problem with it. Usually in people who have partial gastrectomy or completely have taken their stomach out, we see dumping syndrome, but that is all, I think, some hormonal and some chemical change that results in a dumping. So this patient, are they referring to someone without any surgery? They're showing symptoms of dumping?
It's an isolated question, so I think there's probably much more context to that somewhere else. But so I think for that person who wrote that in, if you are noticing, this sensation that you're calling dumping, I would definitely you can start your primary care doctor just to get a sense of what's going on, but perhaps one of the gastro doctors. Okay, so here's another patient. I was told that taking a fiber supplement like Metamucil a couple of times a day would help. I've been doing that for 25 years and have no incidents since. Am I being superstitious, or does that genuinely help?
Grace, do you want to answer this? Okay, I think I don't see any any problem or any side effect to taking fiber supplement. Sometimes few fiber supplements can cause bloating. So usually if someone complains about bloating, I ask them if they take any fiber supplement and ask them to hold off or change to a different brand of fiber supplement to help the bloating.
Okay. Let's see. So can there be an interaction between IBS and urinary symptoms? And could the medications for both interact in a negative way?
Okay, so I mean, it would be more. This would be more. I'm not sure. This is not specific, so I don't know what medication they're on. But some of the medication that we use for IBS, especially the one for pain, can cause constipation, and some of the medication that are taken for urinary symptoms, like for urgency or dribbling, they can also cause issues with constipation. So yeah, definitely, it's better to see the side effect of the medication someone is taking to see there's no interaction.
Yeah, I will say from a primary care perspective, there are a lot of sort of chronic conditions that run together. And I'm sure Dr. Tesfaye can talk about this too, but you know, we tend to see irritable bowel syndrome, say, run with people with migraines and anxiety, and also something called interstitial cystitis, which is a chronic bladder irritation. So there definitely could be a connection, but I think, you know, just like Dr. Tesfaye said, if you have specific questions about your symptoms and your medications, it sounds like probably a longer conversation to have with your doctor. All right, and then what about the role of antidepressants in helping IBS? I know that Dr. Wu touched on this a little bit with the serotonin receptors in the gut, but maybe you can elaborate on that a little bit more about, you know, when you give antidepressants and exactly how they might help.
So yeah, we definitely give antidepressant. Like this is low dose antidepressant, and we don't give it for the antidepressant properties. The group of medicine that we usually use either tricyclic antidepressant like amitriptyline and serotonin reuptake inhibitors. And the tricyclic antidepressant help with, they have some form of analgesic properties or act as a pain medication, so help with the pain symptoms of IBS. But at the same time, it is useful, or it helps more the IBS with diarrhea, because it also has some anticholinergic properties. By so doing, help with their diarrhea symptoms. The same with the serotonin reuptake inhibitors. As I mentioned, there is more production of serotonin in the GI tract as well as in the brain. So the serotonin reuptake inhibitors also help with the GI symptoms. So yes, and usually this is usually my second line treatment. I usually try antispasmodics like dicyclomine or hyoscyamin. And if they don't respond to that, if the pain is severe, and if there is some degree of anxiety, I think it's helpful to try this tricyclic antidepressant or serotonin reuptake inhibitors.
And then, sorry, there's a question here. So we probably have time for one or two more questions, but there's a question here about the there's a home test that is advertised as a substitute for colonoscopy for patients who do not have a history of colon cancer. What are your thoughts on this? So let me just say before Dr. Tesfaye answers this, on June 19th, which is a Friday, so a couple weeks from now, Dr. Steinberg, who's actually one of our retired gastroenterologists, is going to do a whole webinar on colon cancer screening. So he'll go like into all the specifics of the different types of colon cancer screening. So I think just, you know, sit tight for that. But since we have a gastro doctor here, and it's always great to have a specialist answer questions, do you have some brief thoughts on the home stool testing Cologuard, Dr. Tesfaye?
And again, I wanted to say the best test is the test that gets done. So for any reason someone cannot get colonoscopy, virtual colonoscopy, definitely Cologuard can be helpful in finding patients who might have, it is very helpful in terms of picking early cancer or colon cancer. One of the downsides to the Cologuard is it is not very good in picking polyps, which are some of them are precancerous. But for any reason, someone without any family history of colon cancer, they cannot get to their colonoscopy earlier. I think Cologuard might be helpful in bringing those people that have positive Cologuard earlier to their physician to get their colonoscopy done. But it has its downside. But the preferred colon cancer screening by every society in the US, including the American College of Gastroenterology, is colonoscopy. But if colonoscopy cannot be done, or someone is unable to do it, there are options, and Cologuard is one of them.
Okay. And yeah, like I said, we're gonna have a whole talk on colon cancer screening on June 19th. So stay tuned if you want to hear more about the data behind that home testing compared to other types of tests. All right, well, I think that's it for our questions. I don't see any more. Let me just say that Friday, again, we have no lecture, Friday's off. And then on Monday, Dr. Tannenholtz and nurse practitioner Christina Schrack are going to do another update of COVID for the practice. So we've gotten a lot of questions about antibody testing and, when the office is going to open up and protocol changes and all these things. So they'll go through that with you. So, again, the link is public, so you can feel free to give it out to friends. They don't need to be patients of the practice if you think there's anyone else who could benefit from listening. And then another talk, it's either going to be next Wednesday or Friday, probably Friday, is going to be on health disparities and race. We thought that would be an important topic that, it might be relevant at this point in time with all of the racial, riots and everything going on in the news. We wanted to bring some data from a health perspective. So that should be a good talk too. And then we have a couple more, coming up in the next couple of weeks. Stay tuned on your emails. And then of course on our website, we list all of them. And we have our past lectures posted, and then this one will be posted too. So if you have questions, you can always go back and look at the talk. So thank you to everyone who tuned in. Thank you especially to Dr. Tesfaye for giving this wonderful lecture, and then Dr. Wu, who had to step out to do a procedure. So she didn't get to say goodbye. She just wanted to silently make an exit. But so guys, and I'll see you guys on Monday.
Yes, thank you everybody for attending our webinar. If you do have any questions, I guess you can send it. We'll be happy to answer it at any time. Yeah, thank you.
Okay, all right. Have a great day. Have a good Monday. Take care.